But I'll get started. I got quite a few slides. I got a bit excited with this presentation, so hopefully we'll get enough time to get through it all. But basically, we're going to look at surgical, minimally invasive procedures and non-invasive procedures for the treatment of plantar fasciitis, or plantar fasciosis, as some people describe it. So we have different treatment theories of how to approach the treatment of plantar fasciitis. So doctors and allied health practitioners for decades have used several different techniques to decrease the pain and promote the healing of the plantar fascia. Some attempt to break down the scar tissue that is built up. That's that thickening we talk about with the plantar fascia. And others attempt to stimulate healing by increasing local blood flow to the area. So here's a little anatomy we'll just go over so we're all on the same page. So there's three bands of the plantar fascia. We have the medial band, which is here. We have the central band, or what's called the plantar aponeurosis, and then we have the lateral band. So it's really the central band that most people are talking about, that attaches to the medial tubercle of the calcaneus down here, that we describe as having the true plantar fasciitis. So it breaks into 5 bundles that attach to the plantar plates of each of the proximal phalanges. So I like to talk about anatomy trains as well when I treat patients and I explain to them how it all works. So as we can see down here, if you haven't seen this before, this is the work by Tom Myers. And down at the bottom of the foot, so you have the plantar fascia here, which connects up through the Achilles, through the gastrocs, up to the hamstring, through the sacrotuberous ligament, up through the dorsal sacral ligament, up through the erector spinae, and finishes up in the frontalis muscle at the front of the skull. And over on this side, you can see it's a cadaver that they've laid over a real-sized a skeleton. So you can see how it's all connected. So it's just to show people that tension down in the plantar fascia can be coming from areas further away from or proximal to the plantar fascia. So often I start with working the plantar fascia, and I'll work up through the Achilles, and I basically work more and more proximal until I've resolved the problem on the person. Some people might want to start up at the hamstrings and work their way down. That's cool. That's just the way I do it. So some differential diagnoses, we like to, you got to first make sure the person has plantar fasciosis before you start treating it. That's probably the best course of action. So just rule out some of these problems. As you can see in this picture here, that's a pretty obvious one. It's a great big calcaneal fracture. So I wouldn't be treating someone with shockwave or any other things that are going to irritate that. I'd be getting some surgical intervention for something like that. But we also have, so neurologically, we have peripheral neuropathies such as diabetes, idiopathic and nutritional peripheral neuropathies. We have Baxter's neuroma, which is a neuritis. You can also have such as an L5S1 spinal nerve root impingement, causing referral pain down into the heel. Tarsal tunnel syndrome, rheumatic arthritis, or psoriatic arthritis, reactive arthritis, seronegative spondyloarthropathy, a few degenerative plantar fasciopathy, fat pad atrophy, fractures, and plantar rupture. So again, you just want to make sure you're doing some tests to rule out a few of these, so that you're getting an accurate diagnosis before you get into the treatment. So here's a cool picture that I found. I hadn't heard of Baxter's nerve. So it's a branch of the lateral plantar nerve. As you can see, it runs just underneath the calcaneus here, and you can have compression of that, and it'll mimic the plantar fasciopathy symptoms. So that's a good, and often when they do surgical interventions, they'll just check that nerve to make sure there's no compression or impingement there as well. So they kind of do they do both while they're in there. All right, so some minimally invasive procedures. We have PRP injections, we have cortisone injections, and prolotherapy. So we'll just go through some of these. So PRP is a technique where they take someone's whole blood and they put it in a centrifuge and they spin it up, and they get the platelet-rich plasma. It goes to the top, and they use that and they inject that into people. And for the plantar fascia, it has cytokines and growth factors that play an important role in treating the plantar fascia and stimulating all these growth factors and endothelial growth factors and all these other things that you can see on here. So it's a combination of these growth and anti-inflammatory components that they use to stimulate healing in the area. It's basically all these procedures. You'll see they have a commonality of basically it's stimulating the body to heal and repair in that area. So some contraindications for PRP is if they have a local abscess, if they have bleeding disorders, if they're on anticoagulant meds, if they have an acute infection or septic arthritis. So we had a little video here. The sound's not working, but he's just, this doctor here's showing him doing a PRP injection into someone with plantar fasciopathy. So I'll just run it. We'll put links up so you can hear hear what he's saying after, if you like. So he's using ultrasound to guide where to put the PRP. He's basically saying the patient should feel some minor discomfort and some burning while he's injecting them. So we'll just move on. Now, so some adverse effects from PRP, you can get some mild bleeding, you can get some hypersensitivity, some stiffness, some facial flushing, local infections from the syringe. Some people get an allergic reaction, and some people get a bit of numbness at the site of injection. And then some people get some pain that lasts about 72 hours. So pros and cons of PRP. The benefits are usually felt within the first 3 months after the injection. Usually one injection is all that's needed, but most people go for 2 to 3, and it can last up to 6 months. So there's low risk of adverse events, and it has good long-term effects. Some of the cons can be painful procedure. You can often have to get a referral to a radiologist or a sportsman to get it done. And it can cost between about $200 to $1,000 per injection. So if you're getting, if you get 3 injections and at $1,000 a pop, that's $3,000. It's a little expensive. And there's the risk of infection because it's an invasive procedure. And the short-term benefits aren't great. Like the first couple months, they don't get benefits straight away. Usually it takes a couple months before the benefits kick in. All right, cortisone injections. So this cortisone have been used for decades for plantar fasciopathy, and it's kind of falling out of favor because some of these new techniques are stealing the thunder a little bit, like PRP. So it's a steroidal anti-inflammatory, as we all know. And it's usually paired when they inject it, they give it with a local anesthetic. So the anesthetic has an immediate effect in reducing discomfort. But the injection itself is quite painful. I've had a few patients have it done, and they say it's really like a 9 or 10 out of 10 when they're getting it done. Some practitioners will inject a nerve block further up the ankle and like the posterior tibial nerve. So it's a little more tolerable when the person gets it down in their plantar fascia. So contraindication is very similar to PRP. So local abscess, bleeding disorders, patients on anticoagulant meds, people who have an allergy to local anesthetic, acute infections, and septic arthritis. So adverse effects, you can get mild bleeding, you can get local skin atrophy, hypersensitivity, stiffness, facial flushing, local infection, osteomyelitis, allergic reactions, numbness at the site of injection, and mild pain at the site of injection for up to 72 hours after. And you can also get atrophy of the fat pad of the heel, which is you don't get that with PRP. So that's a big difference between the two, and that's a big side effect that obviously if you're losing the size of the fat pad, that's an ongoing problem for that person. And also you get there's the risk of plantar fascia rupture in 2.5 to about 6.7% of patients. So that's where it typically occurs the more injections they've had. So if they've had like 3 cortisone injections, the risk increases. I think it's about 10 times that of a regular person who hasn't had any injections. All right, so pros are you can get immediate relief with cortisone. Usually the short-term effects are quite good. Adverse events are fairly low risk. The cost is relatively low, and it can be administered by GPs, but you can also have radiologists do it under ultrasound, which helps avoid some of the complications. And has good short-term effects. Some of the cons can be quite painful, as I mentioned. Often it's not successful after one. You have to get a few more injections. The effects only tend to last 4 to 12 weeks, so it has a poor long-term effect. Also, you have risks of infection and injection into the medial lobe, calcaneus skin, reversal. Yeah, so you got the fat pad atrophy, which is a big con for that, and all the other adverse events I mentioned. And again, the plantar fascia rupture is a biggie, because usually they have to have surgery to repair that afterwards. So some people go in, they get the cortisone, they get it a few times, and then they feel no pain, but then they go off and run and jump and do things, and they end up rupturing the whole plantar fascia, and then they have to have surgery. So it's not ideal. It's not what you want. So here's some minimally invasive surgical procedures. I actually didn't put the 10-jet on here, so I'll have to change that. But so we're going to talk about the Topaz and the 10x FAST procedure. So this is the Topaz procedure. It's pretty cool. So they inject local anesthetic. And they use this device here, which they call a wand, to deliver radio frequency waves that break up scar tissue in the plantar fascia. And so you can see all these little dots. So basically, they're gonna go in here with this this device and puncture through the skin and the tissue to get into the plantar fascia, and at every spot, and use the radio frequency to break up the scar tissue. So it's purported to increase the blood flow to the area and facilitate healing. And the recovery time is about 4 weeks, and you have to wear a moon boot for about 3 weeks afterwards. And they recommend doing exercises and whatnot afterwards to maximize benefits. So here's a little video of a surgeon using the Topaz procedure. Again, you won't be able to hear the commentary. However, we'll put links up so you can watch it after. So that's the plantar fascia down here. And you can see they're debriding with it. So you can see he's puncturing each of those holes, and he's just debriding little point locations of the plantar fascia. So it's you don't have to make any big incisions. So that's the benefit of these minimally invasive procedures. So this is the 10x fast procedure. So the doctor will hold a handheld device to deliver ultrasonic energy sound waves to the plantar fascia. And again, the goal is to break up and remove some of the tissue, the thickened tissue of the plantar fascia, and stimulate healing. So they also require a local anesthetic for this procedure. And here's a little video of that. Takes about 20 minutes to do the procedure. So again, there's some more some different techniques that are available that maybe some people are not aware of, that you can put your patients onto. So let's talk about some surgical procedures that are commonly done. So you have your partial plantar fasciotomy. There's basically two approaches: the open surgical approach and the endoscopic approach. So you should only send patients basically if they've had at least 6 to 12 months of conservative treatment. So usually most of the stats show that in about 90% of patients with plantar fasciopathy will get better with conservative treatments. So you're only looking about 10% of the population that will require some form of invasive surgery. So with the procedures, there's a partial transection of the plantar fascia to stimulate healing and repair. So again, it can be done endoscopically or open surgery. And it's done to relieve tension as well in the plantar fascia and the superficial back line, as I mentioned, through anatomy trains. So it says there's not a lot of, there's only weak evidence. A lot of the studies, they're not huge numbers, and that's why the evidence is a little bit weak, because they can't do the procedure on thousands and thousands of people. But if I go back there, we'll get to some of the numbers for the different surgeries in a sec. So some contraindications for both of those procedures is local abscess, bleeding disorders, patients on anticoagulants, if they've had any allergy to local or for the open would be general anesthetic. If they have any infections, septic arthritis, if they have venous insufficiency or peripheral neuropathy. Some of the adverse effects of the surgeries are they can damage some nerves while they're making the incisions, or cause a nerve entrapment. The patient can, even after the surgery, still have heel pain. They can cause a neuroma. They can have delayed wound healing. They can get an infection. There's always the risks of the general anesthetic for the open surgical procedure. There's also the possibility the patient could get worse after the surgery if it's a failed procedure. And another one is patients can lose the height of the longitudinal arch if they debride too much of the plantar fascia, because it won't be resilient enough to hold and give them that windlass effect that the plantar fascia gives you when with gait. And also, again, the patient might not have resolved their symptoms and that they presented with. So here's a lovely picture of open partial plantar fasciotomy. So they make an incision usually at the bottom of the heel, and they cut upwards. They cut the plantar fascia and again to release some of the tension and allow it to lengthen somewhat and create some healing and repair processes by doing so. They can also, with the open surgical procedure, they can often, because they can visualize all the structures, they can see if there's any entrapped or impinged nerves, and they can also remove bone spurs if they want to. Surgical wound is closed with sutures and irrigation, and then covered with sterile dressings afterward. And so the pros of open surgical procedure is surgery often offers other treatment to patients who have failed. So that's that 10% of patients that don't get better that I was talking about before. It usually gives them immediate relief. A big part of that is because they're not going to be weight bearing on it for a long time. So obviously it's not really going to cause them much trouble if they're not weight bearing. Usually only one surgery is required for long lasting relief. And again, the open surgical procedure allows direct visualization of the plantar fascia, so they can really see what it all looks like and remove any other problems such as nerve entrapments at the same time. So the cons are that it can only be done in a hospital because you usually need a general anesthetic for that. The patient needs to wear a cast or a brace for 2 to 3 weeks after for recovery. It tends to be an expensive procedure, depending on your where you get it done and your insurance. It's usually about $5,000 to $10,000. It's a long rehab. It's 6 to 10 weeks before they can walk unassisted, and usually 3 to 8 months for full recovery. So it's quite a long time. Again, you have the risk of an infection because it's an invasive procedure. You get scar tissue that forms on the surgical where the scar is, and there's loads of adverse effects. And again, you need a general anesthetic, and 5 to 8% of patients end up with a tender scar. So the scar is quite painful. Even though their plantar fascia pain is gone, they now have a painful scar. So here's a picture of endoscopic procedure for partial plantar fasciotomy. Again, it's only recommended for people who have failed conservative treatment for 6 to 12 months. They usually release the medial aspect of the plantar fascia. Whoops. And they make 2 small incisions about 5 to 10 mils long at below the ankle bone. The surgeon will put in a small camera called an endoscope, and in one of the openings, and a tiny knife in the other opening, as you can see he's doing here, and cuts away some of the plantar fascia to again to stimulate healing and decrease the tension in the plantar fascia and promote healing. And then the incisions are sutured and bandaged up, and they put a sterile dressing on it. So the adverse effects of the endoscopic approach are you can still they can damage some nerves while they're cutting. The patient might still have recurring heel pain. They can get neuromas, delayed wound healing, infection, risk of the local, or sorry, they can do local for this procedure. They don't have to have a general. And some patients, their symptoms get worse after the surgery. And also you can have, if the surgeon takes a bit too much of the plantar fascia away, it can cause a loss in that height of the longitudinal arch, which is difficult to fix afterward. So the pros for the endoscopic procedure, it can be performed with the local or mild sedatives. Surgery offers another option for people who've failed conservative treatment. The procedure can often be done in a hospital or surgical center or doctor's office. Usually patients can walk normally after 3 to 6 weeks. It gives the patient immediate relief. Usually they only need one procedure to get long-lasting relief. They usually have a shorter recovery time with the endoscopic procedure versus open surgery, and they only have to make small incisions, so there's less risk with that. And then patients don't have to wear a cast like they do with the open procedure. So again, it can be expensive, usually similar pricing to the open procedure. They have risk of infection because it's an invasive procedure. Patients get scar tissue formation after the surgical procedure, and there's all those adverse effects I mentioned. All right, so we'll just go through a few stats here. Again, as I said before, only about 5 to 10% of chronic plantar fascia patients require surgery. So I actually haven't sent any, I can't remember the last time I sent a patient for surgery. I had a patient opt for surgery, even though he was getting better with my treatment, because his mate was a surgeon. So that was a little different, but other than that, I usually don't have any patients that opt for this. But it's there for people who aren't getting better. So a lot of retrospective studies show about the success rate from 56 to 96% for most open and/or endoscopic. A lot of the endoscopic studies I was reading, they were showing usually 80 to 90% success rate. Most people that have plantar fasciopathy have about 30% have it in both feet, and some studies show worsening or persistent heel pain even after the surgery, but that was only one study that said that, whereas most of the case studies were showing, as I said, with the endoscopic 80 to 90%, which is pretty good. So let's go through some non-invasive techniques. So we have low-level laser, or what they call cold laser. Another new technique I learned about is called relief. That's how you pronounce that, with the thing over the E. And then we have shockwave therapy. So the low-level laser, again called cold laser as well, is believed to cause physiological adaptations to tissues stimulated via photochemical non-thermal effects on the cells. So there's different types of lasers. There's high-powered lasers, which actually penetrate a bit deeper and stimulate a thermal effect. So that's why these are called cold lasers, because they don't heat up the tissue. So it's more the photons that are causing the physiological adaptations. So you have photons from the laser absorbed by cellular photoreceptors and trigger chemical changes within the plantar fascia. It increases cell metabolism and permeability of the cells and accelerates fibroblast activity. So some of the effects are, it causes neovascularization, it promotes angiogenesis, and increases collagen synthesis. So a study here that I quote demonstrated used ultrasound imaging after they used low-level laser treatment to show that the plantar fascia thickness had significantly decreased compared to a placebo group. So they measured the plantar fascia of these patients before and after the procedure. So the common definition is if the plantar fascia is greater than 4 millimeters in thickness, that constitutes plantar fasciopathy. And so in these patients, they measured a decrease in that thickness with the laser. The exact mechanism is not fully understood. So here are some of the mechanisms, the theorized mechanisms of action for the low-level laser. is that it causes a peripheral neural blockade. Another one is enhancement of peripheral endogenous opioids. Another one is suppression of central synaptic activities, inhibition of histamine, modulation of neurotransmitters, promotion of ATP production, reduction of muscle spasm, and increased production of anti-inflammatory cytokines. So they're not really sure. They're just different theories of what happened. It might be one of them. It might be a few of them. It might be all of them. They're not really sure. But they know something happens and people get effects. So that's the main thing, I think. So some contraindications. So pregnant women, obviously it's a relative contraindication because you're working on the foot. They just don't have lots of studies on pregnant women to prove that it's safe. So that's why it's a relative contraindication. Local tumors or cancers. If someone's got cancer, they're contraindicated, and epileptics, because some of the lasers have pulsed visible light, so it can trigger seizures in epileptics. So there's no known long-term side effects from light therapy, which is cool. It can cause some damage to the eye, obviously, if it's shown directly into the eye or reflects into the eye. So usually people have to wear protective goggles when receiving treatment. So pros for laser are it's a totally painless procedure. Again, there's no adverse events with it. It's relatively inexpensive. It's fast acting, so you can feel changes within a treatment session. Low risk of adverse events, low cost. Again, that I almost doubled up on that. Can be done in most allied health clinics. So a lot of people have cold lasers these days. So cons, you can get skin burns or irritation with that's more the high powered laser. And they show some poor long-term benefits greater than 3 months. And you also have to find someone who has a laser. So this technique, again, it's pronounced relief. It's a new technique that uses electrocoagulation, which is a form of radiofrequency to break down scar tissue within the plantar fascia. The process increases the temperature of the targeted tissue up to 50 degrees. But it also it has a cooling system that cools the superficial skin layer so that you don't get any skin burns. It uses pulsed energy lasting up to 3 seconds. A full treatment consists of about 100 pulses, and there's little or no discomfort at all with the treatment, so that's kind of cool. And the treatment doesn't require any injections or anesthesia, and that usually the foot's placed in a boot for a week afterward. So we just got a little video here. Again, you won't be able to hear it, but there's little clicking that goes on when they're going through the grid here. And you should be able to watch this after if you want to click on the links that we're going to load up. All right. So that's the relief procedure. And so contraindications, again, pregnant women, just because they haven't done a bunch of studies to prove it's safe, local tumors, bleeding disorders, and if they've had a local cortisone within 6 weeks of the treatment. They don't know of any adverse effects related to the procedure. So that's a good thing, but also they haven't done a heap of studies to see what the effects are as well. So pros, gives immediate relief. One treatment is usually good enough to give up to 3 months effect, and there's no adverse events again, and it's pain-free procedure. Cons are it can be moderately expensive procedure, and it's not commonly available. All right, so we're on to shockwave therapy, which is my specialty. So with the shockwave, if people haven't been exposed to it or aren't aware of it, it's been around for about 30 years. So shockwave is a single acoustic pressure pulse. It's characterized by a rapid rise to high peak pressure, followed by a rapid drop in the ambient pressure, and that causes what we call cavitations to occur. And these cavitation bubbles are what cause the physiological changes within the tissues. So the energy from these cavitations promotes repair and regenerative processes of bone, tendon, muscle, and other soft tissues. So this is the EMS device. This is the new device that we've just released here in the picture. And so here's just some physics of how the device works. So there's a projectile in the handpiece that's accelerated via air, compressed air. It hits the applicator here, and the applicator causes these compression phase cavitations, and then those cavitation bubbles cause the physiological changes to the tissues they're applied to. So the energy is transmitted along the applicator. You'll feel when you're using it, the applicator moves. So it's a bit like a jackhammer, I tell people. So you'll feel it moving when you're treating people. So we also have to use contact gel to minimize the energy loss with it. So contraindications for shockwave are you can't do it over air-filled lung or over air-filled tissues such as lung or gut. Again, pregnant women, that's a relative contraindication. I do it on plantar fascia and haven't had any problems, but that is up to the individual practitioner. Again, if there's any local tumors or cancers, bleeding disorders, patients are taking anticoagulants like warfarin if they've had a cortisone injection within the past 6 weeks. Patients under the age of 18, and again, that's just because we haven't done the studies on juveniles to prove its safety, but they have done some studies on juveniles with Osgood Schlatters, so it's safe for that, and also pre-ruptured tendons. So some of the adverse effects. There's pain and discomfort during the treatment, but there's no anesthesia that's necessary. So with the treatment, I'm always checking in on my patients to see if it's a tolerable. I always tell people it should be a tolerable pain. So a maximum about 7 out of 10 of their pain rating. If it exceeds a 7, I usually turn it down, or I'll move to a different area that's not quite so sensitive. They can get reddening of the skin with the treatment, petechia, and swelling and numbness over the skin of the treatment area. Usually, most of these adverse effects will go away within 36 hours of the treatment. Just talking about the safety and effectiveness of shockwave. This study was a meta-analysis, and it included 19 RTCs, which had almost 1,200 patients, and of those 1,200, almost 1,200 patients, there were no adverse effects or side effects or complications. So that's a pretty good track record to have no adverse effects out of almost 1,200 people. So the pros of shockwave gives immediate relief. One treatment can provide up to 3 months effects. No adverse events post-treatment, well, no major adverse events, and it's relatively inexpensive treatment. Cons are it can be mildly to moderately painful. You need to use contact gel, so it can be a little messy. And you need to find a practitioner that has a shockwave device.